Well, thanks, everybody. So I was told that this was a beat down to the death. So, no, I'm kidding. No, but I'm going to sell it like I stole it. So we're going to talk about the clinical evidence for the use of Botox in the treatment of AD. These are my disclosures. And quite frankly, when it comes to the data, clinical data of Botox and ED, they're pretty good. So I think that Dr. Schindel should go ahead and just start crying because there's no gentlemanly way to win this. And I would ask you, Alan, do you feel lucky, punk? Do you?
Always.
All right, so Trinity did a really nice job of talking about what Botox does. So we're going to blow through this. Clinically, it's primarily used to reduce wrinkles, but it's also used for other medical applications because of its mechanism of action. So it's approved for 2 other uses in urology, detrusor overactivity and OAB. And the question is, should we do the same thing for ED? Is it worth using there? So the potential MOA in ED is really through relaxation of smooth muscles, just like Trinity had mentioned, which facilitates this max relax, as Erwin is always talking about, and makes it better with Botox, right? So it can decrease that nerve activity that can hinder erections. Studies have shown improvements in erectile function, and with regards to safety, it's certainly safe for approved uses, and it looks like it's in the 500 plus men in which it's been tested in clinical studies. It's also safe in the use of ED. But don't let me convince you otherwise. Let's let the data speak for themselves. So as the great Warner Wolf, for those of us, yes, I'm getting old enough, who remember him, let's go to the videotape. So Trinity did a great job, and I do this in one slide, showing that the animal studies support the use of Botox in ED treatment, and so do the human studies. So I can just stop now, but I won't. So looking at the studies, in 2021, Abdurrahman published a cohort of 70 men in ED unresponsive to PDE5s. This was actually a double-blind, placebo-controlled, randomized controlled trial, so good evidence. And I'm trying to focus on good evidence. The bad stuff just stays on the side. Treated with a single dose of 100 units of Botox and a control with a saline injection. And what was found was improvements in erectile hardness score, peak systolic velocity, and shim scores in the treatment versus the control group. And these changes persisted up to 12 weeks. And we're seeing efficacy from between 3 and 6 months in these initial studies. 2016, Gandam published a phase 1 RCT, small study, but again, randomly assigned to either a single dose of 50 units of Botox. So now we're looking at dose response. A day after penile Doppler testing in a control group with saline injection, and again, saw improvements even at a low dose in PSV, EHS, and shim scores. Is 100 units of Botox better? Maybe. So 2021 study, also an RCT, looking at 50 and 100 units on almost 200 men, seeing improvements again across these measures of erectile function, maximized at 3 months. And now we're talking about more practical measures. 40% of the patients were able to have sex, right? So that's a pretty compelling outcome measure in somebody who has ED who can't have sex, right? And there were no differences between the two groups at 2 weeks and 3 months, and at 6 weeks, the higher dose was favored, right? So jury's still out, but it looks like maybe a higher dose is better. And how about now even higher doses? So a study of 250 units at 500 units in 2019, looking at IAEF, EF score improvements and seeing clinically significant, as all of you would know by those numbers, improvements in both groups and response rates of 50+% in each group. And you can see partial and complete responses across both cohorts. And then finally, looking at the use of Botox as an adjunct to other ED therapies, a study in 2021 that looked at 123 consecutive ED patients that were poor responders to other PDE5s or intracavernosal injections, and now looking across the board at 100, 250, or 500 units of Botox as an add-on to current therapy, also seeing improvements in IAF scores at a median of 34 days and out to about 6 months. So, look, I'm selling like I stole it, right? But there is still work to do. We do need larger, better designed trials. We need to figure out dosage here. I'll go through the list of grievances that I'm sure Alan will touch on without a chance. And we have to look at other things as well. But ultimately, with regards to efficacy, while it's not a vasodilator, it Can it induce cavernous smooth muscle relaxation to enhance erections? It seems to work. Works. Okay? With regards to safety, systemic side effects, and potential for priapism, we're not seeing that safety signal across 500 plus men. It's not FDA approved. Okay, can be, but we're also doctors. Leave that to your interpretation. We can use these things. And there's no data on long-term safety and efficacy. True, but that's what registries are for. That's what additional studies are for. And the initial signal looks good. And it's temporary, lasts 3 to 4 months. Okay, but look at what we're using. Lasts hours, typically, unless you have an IPP. And with regards to side effects, right now we're seeing very mild side effects and no major issues. The other benefits here are we're seeing fewer systemic side effects versus PDE5s and potentially early promise for men who respond poorly to current treatments. So ultimately, look, Botox works. So, Alan, I gotta say, man, make my day, punk. Go ahead.